Perfect. So this is a young gentleman. I'm going to scroll through this ultrasound here, and I'm going to solicit volunteers to tell me what you're seeing here. So let me scroll through slowly. Number one, so two questions here. The first question would be, what part of the body are we scanning? And the second question would be, any hints as to what the diagnosis may be? And then we can continue with the discussion.
Answer in the chat box, penile scan, because we see a corpus cavernosum and the two spongiosum.
Okay, excellent. So first strike is perfect. This is a penile ultrasound. And then any thoughts as to what we might be seeing here? This is kind of a textbook picture.
Trauma, any history of trauma?
Indeed. So this is like a classic penile fracture. So this young gentleman presented to the ED with, the classic history that predisposes to penile fractures. And just to show you the findings, these are the corpora. So this is the dorsal aspect, ventral aspect, corpora cavernosa. This is the corpus spongiosum, and that subtends the urethra. So as I'm scrolling through, notice this echogenic line here. And as I scroll through, you'll notice that the echogenic line is disrupted in this region. You see it continuous around this corpus cavernosum, but here it is disrupted. And there is a hypoechoic area here, which is avascular, reaching up to the corpus spongiosum. So this was rupture of the tunica albuginea, and the patient presented with a penile fracture with a hematoma on the right side. So I'm just going to show you the sagittal view now. Here is that hematoma, and you see the echogenic line in the sagittal plane being disrupted. Here is the nice disruption that you can see on ultrasound. And indeed, when the patient went to the OR, there was a 1.5 centimeter defect, which they repaired, and they evacuated the hematoma successfully. So just to show you the Doppler images here, there is no vascularity within the hematoma. You see how the cavernosal arteries are well preserved. That is the urethra here, which is collapsed. So the good part was there was no injury to the corpus spongiosum or the urethra. So that is something that we need to rule out while scanning these patients, because urethral injury increases the level of surgical management. And you can see this decompressed urethra right here. So that was intact, not injured. I unfortunately don't have nice pictures of showing you all the vascular anatomy nicely, but then just as a recap, I pulled up this anatomy picture to refresh our memories. So this is the dorsal aspect. Here is the ventral aspect. Corpus spongiosum is on the ventral aspect, and that encases the urethra. Corpus cavernosum on the right. On the left, deep penile arteries are within the corpora cavernosa, and these are the deep dorsal veins, superficial and deep. One of the differentials for penile fracture is thrombosis of these deep veins. The only clinically differentiating factor is when there is thrombosis, the presentation is acute, but patients with penile fractures tend to present with a deformity, whereas those with spontaneous thrombosis may not have that deformity. So I just thought this was like a classic textbook picture of a nice ultrasound case of penile fracture. And then I have one more quick case. I'm gonna.
We've not seen this on ultrasound a whole lot. We do a few MRs. We see it.
Yeah. Ultrasound is quick and easy in the ED if you know what you're looking at. So this patient subsequently went to the OR and was fixed. All right. So here is my second case. Okay. Can you see the screen here?
Yes.
Okay, perfect. So this is an older lady, history of non-small cell lung cancer. Let me show you the PET CT first. So as part of routine screening on the PET CT, so she had been treated, she was doing well for a few years. And then on this PET CT, they noticed something in the liver. You see this small area of increased FDG avidity. And then actually, when I was looking at this case, I noticed another area here that was FDG avid, which wasn't mentioned earlier on the CT. So this was rightly interpreted as a probable MET from the known non-small cell lung cancer. And they did ask for a liver MRI. So here we have the axial T2 weighted images. You can see that she has plenty of cysts in the liver. And then the culprit that we noted on the PET CT is this lesion here. Clearly, it looks different from the cysts. But I was just asking myself, had we not known that there was increased FDG avidity in this lesion on the PET CT, it's sneaky. And it just drives home the message that you have to be on the lookout for anything, any rounded lesions that hide between the T2 bright cysts. This is not bright enough. And then let me show you the post-contrast images. Here is the arterial phase. This is an outside hospital MRI. And so, the sequences are a little different from what we do routinely. But see how this lesion doesn't really enhance. I mean, there are some thin septations here, but it's not a solid enhancing lesion. If you look at the diffusion, again, it's not as bright as the cysts, but if we do not pay attention to the ADC values, this can be misinterpreted and missed as a cyst. On ADC, this was fairly dark. And so this is restricted diffusion, whereas the other lesions are all T2 shine through. So, this was, and then just the renal lesion that took up FDG, was FDG avid, also is a complex cyst with internal septations. I do not remember, this is an older case, I do not remember the discussion, but we happened to biopsy this lesion. We did a CT guided biopsy, and this came back as, any guesses? This came back as a cholangiocarcinoma. So again, to reiterate the point that cholangiocarcinomas can be sneaky, and it was a good thing that this was biopsied, and it wasn't assumed automatically that this was a MET from the known malignancy, because the treatment pathways differ. So this is eye candy, and take-home message is how to look at the liver carefully, especially when there are multiple cysts in a patient with an oncology history. All right, these are my two cases.
Anu, what did the renal mass turn out to be?
So she was lost to follow-up subsequently, and I don't have any follow-up on that renal mass. Yeah.
Okay.
Yeah, this is also a problem in polycystic kidneys when there are so many cysts and you're supposed to be looking for masses in between those cyst-laden kidneys.
Right.
Diffusions are a super helpful tool, I think. Thank you, Anu. Okay, does anybody else have cases? If you do, type in the chat box and we can go in the order in which we receive them.
Roopa, I'll quickly show a companion case.
Yeah, sure.
Yeah. I hope that's the right screen and I'm not showing any patient identifier. So the same case that Anu showed. So we saw this last week on call, a penile ultrasound again. The images aren't as pretty because they couldn't straighten out the shaft to get those nice axial images, but just scrolling the images to show the same findings. So this is where the defect in tunica albuginea is, and then there is this hematoma that extends superficially. And again, two corpora cavernosa, and this is the spongiosis. And as Anu said, it's important to make sure that there is no injury to the spongiosis or urethral injury associated with these penile fractures. So again, a good ultrasound example. And the reason I'm showing this is we have an MR done for the same patient. So it's a nice ultrasound MR correlation. As this was read on call, the prelim read by the residents, I think they're not used to seeing these cases. So they said no injury. And next day, when we put the final report, we said, oh, there isn't like a fracture of the tunica albuginea. So they wanted an MR to make sure Let me pull up the. And this is where we can see, I think this is a T1. I'll get to the T2 also. But the tunica albuginea is seen as this nice T2 hypointense rim, bilateral pairs, symmetric structures. And here we can see the disruption in the tunica albuginea on the right.
Very nice. Did this go on to surgery also?
Yes. So this is the defect on sagittal, and there's an associated hematoma. And on surgery, they found a 1 centimeter defect. Sorry, the images aren't as pretty because this patient, obviously it was hard to, this is the axial T2, which nicely shows the defect in the spongiosa and a hematoma associated with it. It was a good ultrasound MR correlate.
Yeah.
I think that's all I had.
Okay, Nelly, you can go.
Can I go later? I have
Okay,
to, I'm setting up the images.
sure. Does anybody else have cases? If not, I can show some too. Okay, I'll pull up a similar companion one. Just this is an older case. Which screen to share? Let's see. Okay, so if we have not seen it enough, this is another case of a penile fracture with ruptured tunica albuginea and a nice adjacent T1 bright hematoma. We did post-contrast images on this as well, and you can see the hematoma doesn't enhance, and right there is the defect. Same thing, I think the trouble with all these is to get the perfect images because these patients are in so much pain. But I like the sagittal image Gitanjali showed that showed the defect very nicely, but this one has similar findings also. And my next case is a liver case.
I'm pretty impressed how quickly you guys can pull up companion cases.
Well, it's
Very impressed.
epic, right? We keep everything in standard keyword searchable database. So we only help each other. So teamwork.
Nice. Yeah.
That is my next case. So this is a patient in her 20s with no known history of previous liver disease. She presented with right upper quadrant pain and this bulging sensation, and the CT was done outside. The follow-up to the CT was this MRI. The CT pretty much showed the same findings, but I'll just scroll through the MR images. I have arterial phase, post-contrast, portal venous phase. This is like a 3-minute delay in T2 weighted images. So obviously not a small finding, but just to go over some differentials, get your thoughts. Can you see my screen?
Yes.
Okay, perfect. So that's arterial, obviously multifocal, involving a lot of the liver. Liver's big also, and there's even a lesion in this elongated left lobe. Looks like the evil grade tumor signal we see on T2s. Some other ancillary findings we noted where it looked like from the arterial phase to the more delayed phases, there was almost a component of filling in the tumor. There was definitely some capsular retraction. And some areas like this, which seemed to enhance more arterially and had a washout-like appearance on the more delayed phases. So any thoughts, any differentials we would have given? Non-cirrhotic, of course. Mixed HCC cholangio, yeah, that's one of the differentials we gave because some of these features, particularly this nodular area here, looked like there was a washout, but the rest of the tumor looked like there was progressive enhancement, like it had that fibrous content. So that was at the top of our differential. One other piece of history, and this is where always checking labs helps. So this patient had an alpha fetoprotein of 450,000. Does that add any other tumor to the mix? And we see AFPs in that range. She also had a PET CT the same day, which did not show any other primary site of disease. So just a big liver lesion with severely elevated AFP. What's one other thing we need to be thinking about? Any thoughts? So germ cell tumors, which can produce hormones, like choriocarcinomas, which can produce HCG, yolk sac tumors, which can produce alpha fetoprotein. So this one was biopsied, and they hedged a little bit on the pathology at first. They said it's either a mixed HCC cholangio or it's a yolk sac tumor. And then they ran a few more specific tissue markers for yolk sac tumor, all of which were positive. So in the end, they said they favored this as being a yolk sac tumor. So just a few things I learned about yolk sac tumor. Hide my screen. Okay, so these fall in the spectrum of what we call extragonadal germ cell tumors. The usual germ cell tumors we're used to are the GCTs we see in testicles in men and ovaries in women. In the testes, they further subclassify these based on whether they are seminomatous or non-seminomatous, and the seminomatous ones obviously respond to radiation. And in the ovary, they can be immature or mature cystic teratomas, rarely yolk sacs and choriocarcinomas. But remember, these same pluripotent germ cells can occur anywhere and result in tumors. So we see these commonly in midline sites, like in the intracranial germ cell tumors. In the mediastinum, we're used to seeing teratomas, retroperitoneal teratomas, sacrococcygeal teratomas. So like that, yolk sac tumor is one tumor in the spectrum of gonadal or germ cell tumors. So you suspect this when you see a young patient with a non-cirrhotic liver, no other risk factors for liver disease, very, very severely elevated AFP. Yes, HCC can give elevated AFP when it's well differentiated, but you don't see it in the 400,000 or so range like this patient had. And of course, we want to make sure they don't have any other primary, like an ovarian yolk sac tumor or a testicular yolk sac tumor from which this is a metastasis. Hepatoblastoma, if the patient was younger, can have a very heterogeneous appearance like this, mixed HCC cholangio, and neuroendocrine mets, which can do anything, some of the other things in the differential. Very nice paper by Cookie's group on some of the complications and unusual imaging manifestations of these germ cell tumors. There's something I didn't know about. It's called the choriocarcinoma syndrome. When you have choriocarcinoma mets, these can apparently cause little pseudoaneurysms in the liver, which can then spontaneously bleed and then present as a large subcapsular hematoma with shock. In the lungs, the same mets can bleed and patients can actually present with hemoptysis and diffuse alveolar hemorrhage. So unusual liver tumor, but something to think about and utilize tumor markers whenever it helps you. Okay, my next case.
Roopa,
Yeah,
can I share my case and then alternate with you?
Ellie, sure.
It'll be easier so that I can pull up the cases as we go rather than showing them all at the same time, if that's okay. Great. Okay, so I'm gonna, can you pause the recording for a second? Just want to make sure. Thanks a lot. I appreciate it. Okay, great. So this first case, this is a patient who came in through the just a accident, like a motor vehicle accident, and had a CT through the. Hold on, is this the right one? Yes, yeah. So I had a CT, pre and post CT through the ER, and we astutely picked up this area in the left liver that's a little atrophic. I had a more convincing, there's a better, sorry, here's a better one, sorry. That was prior, that was originally, but then this was upon a presentation to the ER after a motor vehicle accident. And we astutely picked up these findings in the liver. There's a little bit of bildyl, segmental bildyl. There's a few what looks like cysts in segment 3. And this was new compared to at least a CT that we had a few years prior. So what do you guys think about that?
Is there any lesion at the apex of that building?
Not anything that's conspicuous on CT. Let me show you the. Does this help?
Vascular problem that knocked off blood supply to the left lobe and caused atrophy. And
I don't see a vascular lesion or vascular shunting or anything. Patient's otherwise pretty healthy. No history of liver disease. So we went ahead and got an MR and with MRCP. So that is. So I think the MR, so here's the T2 of that area. Here is contrast enhanced. There's no definite lesions, nothing that's enhancing. The ducts are not thickened or edematous. And here's a coronal if you want. There's no restricted diffusion. And then on MRCP images, this is what we see. Any thoughts?
tumor, I'm guessing, right, Nelly? If you're saying there's nothing, no soft tissue around it, no diffusion, so probably not a tumor downstream. So stricture from something else.
Yeah, so that was our differential, like a benign stricture downstream that's causing kind of like upstream bildyl. The other were biliary lesions was something that we had also proposed. So we recommended a hepatobiliary study with EOVIS. And this is what we got subsequently. I don't think it was that helpful. I think it would have been nice to get the 50-minute delay to see the contrast kind of more into the biliary system. So on like when I looked at the MRCP, the cystic lesions, I was able to trace. There's a what I think is a communication between the cystic lesion and the biliary system, right there. And I was able to do the same thing for this other cystic lesion on the reformats. It's harder on the coronals, but when I reformat this on axials, I can follow it into the biliary system, or communicating a little channel that communicates with the biliary system. Any thoughts about what that could be? So I thought this was an IPNB. I know Arti has presented this case, and or has presented IPNBs in the past, and this was, so IPNBs are like IPMNs of the pancreas, and they're important because they're precursors to cholangiocarcinoma. In fact, I think on one of the studies I'm going to show you, it says like 80% will harbor or become cholangio. In contrast to IPNB, which is only a minority that will develop into sort of pancreatic cancer. So that's why they're treated surgically, which is kind of challenging. So, because this was a totally incidental finding in this case. So it's really risks and benefits of a surgical option versus waiting versus just active surveillance monitoring. So anyways, IPNBs, there's a great AGR paper that goes over, great review paper of the IPNBs. I didn't realize there's like 4 different histologic subtypes. And the most common one is the pancreatic biliary, but you can also get, I guess, intestinal lining as well as gastric and oncocytic, which is awesome. I don't think we can tell those things by imaging. And the analogy is to papillary IPMNs of the pancreas. So here the similarities and differences. I think this is a really important difference, which is how much of them go on to develop invasive cancer. Biliary IPNB, 70%, in contrast to just 20% of pancreatic IPMN. So I know depending on the size, we actively survey IPMNs with biliary IPNB. I don't know if surveillance is something that we do as standard of practice, but because of this high risk of invasive cancer, I think typically surgical resection is often what is recommended. The other interesting, on imaging, there's different types of presentations of IPNB. You can have like a lesion with upstream and downstream buildup, and we didn't see a lesion here. Well, we have a cystic lesion. So this is unique to IPNB. So if you have this imaging finding, there's very narrow, maybe non-existent differential diagnosis. And then you can also have less sort of non-specific findings. So if you have lesion with upstream DIL, then you would include these other DD items in the DDX. If you have disproportionate dilatation without a lesion, then you would include pyogenic cholangitis, choledochal cyst. And then if you just have a cystic lesion, then it could be an MCN, localized Coriolis, or a hepatic cyst. So in this case, I thought it had these imaging features, with the cystic lesion with upstream, and it's secreting mucin, and that's why we get that ductal DIL. So to me, it looked like an IPNB.
Nelly, was there a diffusion that you showed?
I did not, but let me show you the diffusion.
Okay. Was the IPNB?
Here's the ADC. Oh, what? Sorry, go ahead.
No, go ahead. Good. No, I said the IPNBs we have seen, some of them are more a long segment involvement with diffusion restriction within those.
Yeah, I don't see any.
Yeah,
is that something that's necessary, or is that?
No, this one looks more facilitated, but then most of those which have a neoplasm associated with them will have some diffusion. This one's
That makes sense. Yeah, like that's where the lesion is growing, or the invasive component at least.
Yeah. Nice case. Okay, does anybody else want to go next, or if not, I can keep going. Okay. This next one is an older patient. She has had a pelvic procedure done for urinary incontinence. And I'll just scroll through the images, and if you figure it out, that's great. If not, I'll tell you more history. So these are axial T2s. She actually came in with a draining tract in between her gluteal folds. So this is axial T2. Non-fat sat and fat sat images. And then these are axial and coronal post-contrast images. I think these were the more helpful images. First to figure out what sort of procedure she might have had, and then next to see what the complication of that ended up being.
So there's like it's like a urethral suspension procedure, like a
Right.
trans-obturator
Yeah.
approach.
Yeah.
And there's all this inflammatory.
Right. So this was actually an attempted trans-obturator, TOT, trans-obturator tape placement, which, like Nelly said, is one of the mid-urethral sling procedures. And you can see where their trocars have gone because these slings get anchored in the obturator membrane or fascia. And then arising from that left-sided tract, now we have a secondary dissecting tract, which has formed almost like a vaginocutaneous fistula. So this is a known complication. So with the trans-obturator ones, these are known complications. They, because the way they are anchored to the obturator membrane or fascia, they can have thigh pain, they can have these fistulae which form. So just to show the differences between the two types. So this is the more horizontally oriented what we're seeing. So the trocar paths look exactly like how we see them on these post-contrast images versus the retropubic ones, which have more of a V-shaped configuration. So with the TOTs, the risk is more of having thigh pain and these fistulae. With the TVTs or the retropubic ones, it's more organ damage to the urethra, bladder, osteomyelitis of the pubic bone, etc. So this was just a good case of complication from a mid-urethral sling procedure. The sling itself was placed years ago and the patient returned with this draining tract and the medial aspect of the thigh. So these things, they form blind ending passages which are prone to getting infected even years later after the sling has been placed. So looking into surgical history is important. And once you know the configuration of these tracts, it's very easy to figure it out.
These slings, I don't think they're done under imaging guidance, right? This is like,
They're just done in the ORG ones.
yeah, and it's done blindly, I think,
Yeah,
right?
that's why the trocar can go wherever it wants to, particularly if they have a little bit of variant anatomy, they can dissect into some unknown places because they're not image guided.
Wow.
Then I have
Okay, I'm gonna share my,
you want to go, Nelly? I can
yeah,
go.
is that okay? Can I alternate
yeah.
with you? Okay, that'd be
Yeah.
awesome if I could, so that'll make it a little bit easier for me to pull up cases. Okay. All right, so this is a patient with pelvic pain. Okay, and then here's your sagittal. Any thoughts from anyone? Coronal.
Is that a tube?
Tube. Where is the tube? Sorry, is that a tube? Can you be a little bit, expand on that?
I think on the sagittals, maybe.
Sagittals, okay. Okay, where?
I think it looked like next to the rectum.
Next to the
The
rectum.
tubular structure, the cystic structure.
Oh, this thing.
Yeah.
Oh, yes, there's a retrorectal cystic thing.
Is
and
that what
it's-
you were trying to show, or that was not?
But that is an important, that's one of the findings. There's another one.
There are big fibroids. One of them looks.
Yes,
very
yes,
dark.
there is a large fibroid. This is our typical
I think there's scarring between the
And-
posterior uterus and rectal wall. So that's like an endometriotic deposit.
Endometriosis, yeah.
Yes, exactly. And
The mushroom sign.
That mushroom.
mushroom sign. Yes, this is exactly what this is. It's a mushroom sign right here. And, you know, I feel like until you see it over and over again, it's kind of hard to pick them up, especially if they're small. So this is an example of DIE, deep infiltrating endometriosis. Here it is, this T2 dark, and they don't have to be T1 bright, and this one wasn't. Here it is. You see, she does have endometrial implants elsewhere, but in that area of that scarring right here, it's T2 dark. And in this case, you know, it's adherent to the anterior rectal wall. So our gynecologists, they want to know how deep it's invading. If it's like 50% or more, that changes if they just scoop out the DIE versus do a segmental resection. They also want to know the circumference of the bowel loop that's involved. If it's, what was it, like, we say greater or less than 50%, I don't know, they get colorectal surgery involved because it's a more extensive procedure. So these are sort of the pertinent things they want to know. You know, we have these awesome RadPath or conferences with our gynecologists where we review all of our cases pre and post-op, and it's been really informative, you know. And one of the things we need to know is like superficial endometriosis. It's very hard for us to see those, and that's okay because, you know, they don't expect us to see it, but it's cases like these that helps them because it then helps direct their surgical approach and for patient counseling, right? If you know, and sort of things like that. So this is a great example of the mushroom sign DIE that's infiltrative and involving multiple structures here. So this was a pretty lengthy procedure for them. And, you know, so that's what we want to try to do when we read these cases. And I feel like until you've seen multiple cases of DIE, it's really hard to pick them up because they're so subtle. They don't, you know, and I think T2 for me is really the best sequence. And what the other thing that I have come to appreciate is architectural distortion. When there's distortion of the structures, you know, that kind of like clues me into the finding. And then what Kater was that retrorectal presacral cystic, they think it was just like a you know, there's just adhesions and scarring, so it was just encapsulated fluid, trapped fluid, rather than a retrorectal cyst.
Nice case, Nelly. A lot of confounding findings too that draw your attention away. But somebody said this at one of the SAR meetings earlier this year, that in their dictations, they have a separate template for the rectovaginal space and cul-de-sac, which I think is a good idea because then you look individually at that space as a compartment. I think we pick up a lot more of these small endometriotic, the architectural distortion, like you said. Okay, does anybody else have cases? Steve's saying he never gets these cases.
Yeah, I don't know why my GYNs here are not referring for imaging for endometriosis very commonly, but you know, I enjoy seeing them when other people are showing them, but I'm seldom put to the task here.
Okay. Okay, if anybody else has anything, I'll show one quick one. So this was a young patient.
Oh, sorry, can I make a quick comment? So in our, we do have a very developed endometriosis program here, and the other thing that I came to learn is the value of ultrasound in evaluating DIE. I don't know if you guys have much experience, but we have one of our radiologists who reads ultrasound, Scott Young, is like a pro at this, and like there's like pretty significant deep maneuvers that he does and whatnot to look for DIE using ultrasound. It was actually pretty phenomenal.
Wow, that's a challenging modality. It's hard enough to see on MR sometimes, and to figure that on ultrasound would be something nice. Are there any papers or something you can share, Nelly?
I can ask him. He does all of our endometriosis ultrasound. So, he sees them a lot.
Nice. Okay, so this patient came in with history of right groin swelling. He was thought to have right inguinal hernia, which they quote reduced in the ED. But soon after they reduced the hernia, he had 2 episodes of severe bradycardia. He bradyed down to the 30s, nausea, vomiting. So then they decided to get imaging on him.
Did he only have one testicle in his scrotum?
Right. So what they reduced was his other testicle, right? That's the one high riding here up above the inguinal ligament. So this, I think they mistakenly thought this was a loop of bowel, and because it's so rich in nerves, they triggered a good vasovagal response and he bradyed. And this is just a little bit of fluid in that patent processus vaginalis. And you can see there's only one testicle in the left hemiscrotum. So this was just a mistaken identity of an undescended testicle, which was inadvertently thought to be a hernia, and they attempted reduction. I think the coronal images show it really nicely also. So in the undescended testicle spectrum, there's 2 things, right? There's the true undescended testis when the testicle is following its path, but it's just not yet reached there. Or there's ectopic testis when it's deviated away from its path. Regardless of where it goes, it can be source of confusion. These undescended testicles can torse, they can be mistaken as appendicitis if it's in the right lower quadrant, or some other pathology if it's in the left side. And then they do carry a higher risk, particularly of germ cell tumors. So telling the surgeons where this undescended testicle is really important. If it's close to the inguinal canal, then they can fix it with an orchiopexy. But if it's intra-abdominal, they may actually have to do a diagnostic laparoscopic evaluation to find where the testicle is. And the ones in the abdominal cavity may or may not be viable. So if they're non-viable, they will go for orchiectomy. And regardless, some surgeons believe you have to fix all of these, because at least then if there is a risk of malignancy, you can do surveillance on these if you do an orchiopexy. So management does change based on where these testicles lie. So it's just a simple case of undescended testicle not picked up on clinical exam, unfortunately. And the claim was that he was very tender to exam, so they couldn't get a good exam on him. And they only reduced his hernia. All right, that is all I have.
Okay, I'm going to share my screen.
Yeah, I'll stop sharing.
Okay, so this is a patient that we were following actively for small renal lesion. So this was the initial small renal lesion here on the right. That's your, and so let me get, that's your T2. Here's your arterial. Nephrographic. Let's see. Here's your nephrographic. Any thoughts on this? Oh, let me give you the pre-T1s to look for protein. None. Any thoughts? DDX?
Small papillary.
Yeah, that's right. Definitely within the differential. So we followed this up on our active surveillance program. So this is a year later, very similar appearance. Here's our post. T2 dark there, right? There's a little bit of something in there. And then this was a few years later. We've been doing regular surveillance. A few years later, we have this one. Here. Now it's getting bigger, just very slowly over a course of multiple years on active surveillance. So now this is what it looks like. There's
I
your
have to
tumor.
wonder where you would end up on the clear cell score, the,
Oh yeah, yeah.
I'm starting to, I'm
I've
starting to use that clear cell likelihood score, I think it is.
yeah, yeah. How is it good? How do you like it? I haven't started it. I mean, I heard I haven't talked about it, but Pedrosa.
I put it to use about 2 or 3 times in the last few months.
Oh, okay.
It, I think it leads me to, it's a good algorithm to take me to, kind of a quicker algorithm to get to the types of findings that you use to run to things like papillary RCC versus AML with no fat versus things that are more consistent with clear cell.
I wonder where this would fall.
Well, that's what I was thinking.
Yeah, at the a few several years ago compared to it's over time, like when we started surveying. So yeah, that's exactly right. So we as it was it Roopa, I forget who said papillary, but that's definitely one of the differential, right? It's too dark. We usually think of it being hypoenhancing, and then they peak in nephrographic phase, but it's never as it's not iso to cortex, right? It's always hypoenhancing relative to the background. If you had a CT non-con, papillaries are usually hyperdense because they have a lot of muscle in it. So here, right, that fits the picture, hyperdense. So I think they use a cutoff of like 45 or something. And it was growing. So once it reached over 3 centimeters, they decided to ablate it, and they did an ablation biopsy, and this came back as clear cell. Grade 2. So the teaching point, as Steve referred to, is, you just don't know. I mean, it can kind of read the book and then still turn out to be clear cell.
By the time this one's getting bigger, it looks a little bit more ugly and suspicious.
Yes, yeah, and then we started to have restricted diffusion too, which we didn't have before. So that's probably there.
We're in a totally different era now, though, honestly, than we were, 15 or 20 years ago. In the early era of cross-sectional imaging, a small renal mass would end up with a nephrectomy, and then they invented the partial nephrectomies, and now we're in the surveillance mode. It's very different.
Yeah, and now ablation is being accepted as standard of practice now for small renal lesions.
So Steve, I just pulled up this predictability score one, and I think this lesion would have still fallen under papillary.
Oh, is that, yeah.
Yeah, I think this is the score we had shared earlier, right? I remember. So it was iso intense, iso to hypointense. So at the top of that list was anyway papillary RCC. And then if it had other characteristics, I have to look at this too, but this is what
The tough part of this one is there's some vascular enhancement ratios. You got to start getting out calculators and stuff, and that's where you start losing me.
Yeah, I guess the red box means the enhancement. The more it is enhanced, the higher it is predictive of a clear cell RCC.
That's right.
Less enhanced, so it's favored to be a papillary. So I think even if we had used this algorithm, we would have arrived at this was probably a papillary RCC, not a clear cell. All right, nice case.
Okay, I have another case.
Go, Nelly.
Okay. Here you go. Okay. Okay. This patient came for dysphagia. Let me pull up. Okay. And what else? A patient had prior workup. But I'm going to withhold that information because it'll be too revealing for the diagnosis. Anyways, so all right. So what do you Would any, let me see if I can remove the calipers. Okay. Okay, there you go.
Have they had any surgery, Nelly? The
No surgeries.
stomach didn't look very normal in caliber.
Yep, stomach looked normal. Yep.
Yeah.
So, I mean, there's no filling defects. There's no focal strictures, no, sort of nothing that kind of stood out to me. And then there was a little bit of reflux, and then we got to swallowing the barium tablet, and it didn't go. That's where it was the whole time.
So impacted.
Yeah, so the finding is, what is the finding? Let's see. Do I have better images here? Yeah, kind of, yeah. So this patient had a biopsy, had an endoscopy and biopsy, which was what kind of raised the differential to consideration. So the finding here is just long segment narrowing of the esophagus, all the way from the cervical to the distal esophagus. And the barium tablet, as we know, is 13 millimeters. So it's all of it. It was all measuring under one centimeter at 1 or around 1 centimeter throughout the entire length of the esophagus. So what would be in your differential for patients with long segment, kind of just diffuse narrowing? So this patient had lichen planus. So here are some examples in the article. I think it's also HR. Patients with lichen planus, who, and that's the finding that we see. It's just a very long segment narrowing throughout the length of the esophagus. And the other differential consideration that we add is EOE. Eosinophilic esophagitis. I might have presented a case before with EOE. There's other manifestation of lichen planus, including sort of these focal strictures. You can get a patient. So here's one patient with lichen planus, and they have both strictures and these little like outpouchings, intramural pseudodiverticula. And then here's another patient who had kind of narrowing in the distal esophagus. Smooth taper stricture. So, multiple like presentations, and one of them is long segment narrowing, which we had in this case.
Nice. The only other thing that comes to mind with long segment narrowing is caustic strictures, like when people ingest caustic substances that travels the length of the esophagus. We've seen a few narrowing because of that.